to 7, then you're not going to.
Yeah.
So we
So
use a
you just
suction.
like plug them up, you get the catheter in and just like drain it over the sink.
Cool.
I drink it. I'm kidding.
Hey,
It
hey,
goes
we're
into
gonna.
a suction thing, which is really loud, which is another reason I have to leave the room because I don't like sounds. I mean, I don't have like any weird issue with I have a mental disorder. I just there's so many sounds and
I don't
like
like the
everything's
suction
beeping
sound
at
either. I'm
you
with
and
you.
it's really loud. The motor's really, really loud and it's at a frequency that just is just like
I get
penetrating and
it.
I just can't stand it.
I get it.
So I leave the room.
Yeah, it's
Oh no,
live.
I
Anything
don't stay in there
dinging,
while they drain those things. No
anything
way. It's so
dinging at
boring.
me, I just want to throw a baseball at.
I don't have a lot. Like I'm one of these people. Like the moment the procedural part is done, I can't get out fast enough. So like ports,
Yeah.
uh, if I put in a port, my least favorite part is suturing it in. Like there was even a time in my last job where on occasions if I was really busy, I would put in the port and have the PA suture it up. Uh,
Oh yeah, yeah. No, I remember in residency, my attending. I think I was sutured a port. Like 45 minutes later, he looked in and he basically swore at me and told me I was an effing idiot. And I was like standing there trying to suture this port. But then during fellowship, um, one of my attendings was an ex surgery
mhm.
attending, and so he taught me how to, he was really meticulous with sutures. So it
Oh,
became like a little mission of mine to have like a perfect, I tell every patient I want to make them bikini ready, which
wow.
I don't like, even if you're like an old guy. And then I used to do a running mattress,
Nope.
but I would have this beautiful little opposed skin. And then I would do the running mattress and it would jack it up because I was never like, and so basically I do deep and then I glue them. And then,
Mattress always looks like I jacked it up. Yeah, it was like one of my very happy moments was when I read that SI article that basically said that you don't have to do running subcuticular. It doesn't make a difference. So I just do, you know, 3 deep dermals, glue, and done.
yeah, yeah. I love ports. Those are like the most fun.
Are you getting many ports, Mary, in the outpatient?
Not now. I used to do a ton of them,
Yeah.
and I had like, I used to. Well, I won't say it if this is being recorded, but I got
Oh,
pretty
we'll-
fast at them.
yeah.
And that was I just love doing them. But yeah, the surgery groups, the oncology groups around here realize that their surgeons, like their breast surgeons, could be putting them in too. So, and I
Yeah.
just haven't made a major push for them.
I don't really like them.
Oh, you don't?
Really?
I don't hate them. I mean, I just don't love them. But you know, the thing, I mean, in my last job, I mean, I have like a huge repository of like really shitty ports that the surgeons in town did once they started trying to do them, and
Yeah,
you can make a whole business out of fixing those things. Probably
yeah,
shouldn't release that part, um, but
yeah. I agree.
yeah.
Because especially from the left, I mean, I hook up the little hub on the left after I place it fluoroscopically,
Mhm.
and you hear all the time people just put in, they cut the catheter the same length on the left, for every patient, which is obviously the wrong thing to do. Anyway, I can tell you about a case I did.
Yeah, let's
Not
Yeah.
do it.
anything.
Exciting.
So this is take two. We're live
Oh, we're
on
live.
YouTube. Yeah, we're live, and
Never
we have
been
Mary.
live before.
And for anybody who didn't hear at the beginning, we are doing a post weekend kind of Monday morning quarterback, discussing some call cases we have on for this week. We have Michael Barazza here, as well as Mary Constantino has just called in. And so for anybody joining us now, I'll let you tell us about your case, Mary.
Well, actually, Mike should talk about call.
Yeah, let's do
Mike,
it.
talk about call.
I mean, hit or miss. I don't love it, but I had kind of a light one this weekend. So in Louisiana, when it gets cold, nobody does anything, and by definition, cold is less than 60 degrees. And so I had like one of the lightest weekends I've had since I moved here a year and a half ago. I even texted my boss. I was like, "Is everything okay? You know, I don't. There's nothing going on." He's like, "Oh yeah, yeah. People just stay inside." Um, so I did combined diagnostic and IR call this weekend to make a little bit extra money. And the IR call, usually it's pretty busy on the weekend. I expect to do, minimum of, 2 cases a day. But I didn't have too much. I got a lot of phone calls. Stroke is what usually keeps me the busiest on the weekend. Stroke, trauma, and just a smattering of normal weekend cases like drains, nephrostomies, things like that. So I did a nephroureteral stent on Saturday, and then I had a GI bleed on Saturday, and then I had my diagnostic shift, and then I had a bunch of phone calls about strokes that none of the patients were candidates, and then on Sunday I had another GI bleed. The first GI bleed was kind of interesting. I'm curious what you guys think about this. It was just a huge duodenal ulcer that had gotten treated endoscopically, but the patient kept bleeding, was on pressors in the ICU, getting a lot of blood, and so they called me, can you come and embolize? No problem. So what you see commonly, of course, with heavy blood loss and pressors is, you go in there and you shoot the celiac, and it looks like a newborn celiac. They're just so small, just, it barely enough, barely big enough to fit a microcatheter. And you get in there and you're sizing coils. I was going to embolize the GDA, didn't see a bleed, didn't expect to, just saw some arteriospasm. You look at it and it's like, well, am I sizing these coils based on the size of it right now, or the size it's going to be once this guy recovers? And, you can't put a 7 millimeter coil in these spasmed down gastroduodenal arteries just from vasoconstriction. And so, generally I just go as big as I can get in there and just assume they're not going to fly. I've never had that happen, but I've always wondered what happens when these things spruce back up. I mean, you'll sometimes see, as soon as you're done embolizing on the table, they'll kind of, puff up a little bit, get a little bit bigger. I don't know. What do you guys think?
Yeah, I mean, I don't, I hear what you're saying. Like, basically, after, the bleeding's over and, they're tanked up, and you're thinking the vessel then dilates, and then the coil could free up and move somewhere. Is that what you're saying?
It could free up, or it just may not be sufficiently large. I mean, we're talking about this guy, big guy. I would say on average, if I'm coiling a GDA, most of the time it's somewhere between 5 and 7 millimeter coils. I'm trying to go 6 to 7 at the end. But this one, the biggest I could go was 4 millimeter coils, and so you hope it shuts it down, but. And it did. The guy did great, but you gotta wonder what that's going to look like when his vessels are back to normal size. He's gotten past his vasoconstriction.
Yeah, I wonder if just enough
if
clot forms around it that it ends up being okay. Sorry, Mary.
If you can't get a coil if you can't get it in, you can't get it in. So I don't think you have a choice.
Yeah.
You got to just put in what will fit, the largest that will fit.
I've never had any issues with it, probably because I'm just so good. But I don't know. We'll see. He did great.
Or they just all have heart attacks later, and you don't know about it. You're like,
Never
wow, I
know.
did great.
We found a coil
So
in his.
do you do radial
For
access
GI
for
bleed?
this?
Sometimes I try not to, for a handful of reasons. The main reason being that my techs hate it, and it is there's some that are more comfortable with it than others. I've got some really good ones where I work, but it's not the standard for our lab, and so anytime you're not doing something that's a standard, especially on a weekend, it can kind of slow things down, and and then there are equipment issues. I don't love the base catheters that we have here for, I do radial more for like pelvic bleeds and trauma than I do for GI bleeds, because a lot of times those patients are in a binder and you can't really get to their femorals, and so that's when I'll more likely go from the radial. But sometimes, and this is my problem, I need to better outfit our lab for cases where I have to go farther for taller patients, but I'm just still a lot faster femoral.
I think that's an argument for doing elective cases radially. I mean, if I had my dream, all of every IR would be just as fluid radial as your groin, and that takes doing all of your elective cases radial until it's like using your left hand just like you use your right.
Totally.
For those instances, I did a GI bleed. I don't really take call, but I was taking call. I don't know, a couple months ago. I had a 91-year-old on pressors who was basically like pulseless, and I just got into her radial so fast. And I kind of liked it because I could sort of do that while the rest of the room was figuring out what they wanted to figure out. Like
Absolutely.
tucking a groin takes longer, and I could just dive in. And so they get that wrist put out, and they have a little prep on there. I could just start moving right away.
Totally.
But I did ultrasound was really tough. It's so calcified. So I don't obviously do a lot of radial older people because I do a lot of UVE, and I try to avoid PAD with radial, but man, that radial artery was so calcified. And so I couldn't really see it with ultrasound. So I just like went back to my internship days and blind stuck it. And just even the wire was just like calcium all the way up. And then I got the catheter down and I was messing around a little bit, and I just like, this feels so wrong. And so at that point, I probably spent, I think I got into SMA or something, but after like not too long a time, I converted to groin, which at that point I couldn't even, I don't know, I can't really remember, but it was very difficult to like use ultrasound. So I ended up doing a blind stick into her groin too. When I couldn't feel a pulse well there either. But anyway, groin ended up being a better option. But the team was really slick in terms of getting radial going.
Yeah. That's really helpful. I had one maybe 3-4 weeks ago. It was a pelvic trauma, just extraordinarily widened SI joint. Symphysis pubis, and it's one of those where like, you see the X-ray, and you're just, I was doing a diagnostic shift that night too. I saw the X-ray, and I just texted my wife. I was like, well, I know I'm going in. I didn't have to see a CT or anything. Just knew it was happening. And sure enough, the trauma surgeon called me, and he was like, hey, we need to get these hypogastrics embolized. I said, no problem. Called in the team. And, I get there, and this guy has these massive gashes in his groins, just from road rash. And then he's got this huge pelvic binder on. There's no way to get to the groin. It was like, okay, well, let's just go. Let's go radial. Prep the left wrist. Like, oh, he's got an open wrist fracture. It's like, okay, well, prep the right wrist. It's like, he has another open wrist fracture. And I was like, well, I don't want to go brachial. And so I ended up just, I ultrasounded. I found the radial artery just a little bit above the fracture on the left. And what I've seen with these ones, when they've got a ton of bleeding, their radial artery is tiny. It's one that in an elective case, I would say, no way, this is too small. I'm going to have to go femoral. But I didn't want to take his binder down. And so I was like, well, risk thrombosing the radial artery, but you weigh the other option. You could also risk dying. And so I chose, let's just take the radial artery. But, my debate when I was accessing it was like, do I give, the radial cocktail? Do I want to give this guy heparin? Do I want to give him verapamil? I chose no, and just accessed it. It was so small, looked really cool. People were very impressed, which is always nice. But got in and, gel foamed the radial arteries. The interesting thing was, though, the binder was so tight that I got the base catheter down and I got stuck. I was like, I can't advance it anymore. Like, what's going on?
Wow.
I realized I got stuck by the binder. Somebody did a really good job with the binder.
Wow.
So I ended up having to take an Amplatz and basically like barrel through. Finally got in, but for being honest with each other,
Cool to do an angio with a binder on and up and down, like on. And
I did. So I waited till I embolized and took it down, and then shot it again. I didn't see any extravasation, but I don't always anyway. But what I did do was I selected both internal iliacs again after the binder was down, and there was still some flow, so I just squirted a little more gel foam, and that was that.
You gel foamed the internal iliacs?
Yeah, both of them. And then I called the orthopedic surgeon after. I was like, hey, man, you're going to wonder what this thing is on this guy's wrist when you're going to wash this guy out. It's called a TR band. I don't know what you're going to want to do with it. I had no choice. He was like, ugh, okay.
Raza, you're supposed to say, hey, would you like me to leave an art line in for you?
Right.
Yeah.
There you go.
And they're like,
I
wow, you're
didn't
so
offer that.
great. You got access into the radial artery for us, and you embolized.
I should have done that, but
That's what I always loved about trauma cases. Is just, here's your art line. I'm not, you don't have to worry about pulling it. They usually need an art line anyways. So somebody in the IC will pull it down the line when necessary.
Aaron, I remember when I was a fellow at Penn, and we had to cover Presbyterian, which was like a good 15-minute walk if you're going to walk it. And I remember being on call. Our call as a fellow was just absolutely horrendous. Like we had like a little tracker on the phone, and we realized that on call on an average consult day, we were walking between 8 and 10 miles in the hospital, just from one to the next. But I remember there was a trauma case that we did, and we left the sheath in, and I got a call from the trauma team like the next day, like, hey dude, we need you to come pull this sheath. It's like, I'm going to kill you. And so I remember to go, it was like 100 degrees, walking over to Presby and having to pull the sheath and hold pressure for 20 minutes. I'm like sweating. I'm furious. And that's probably why I don't leave sheaths anymore.
Oh, got it.
They probably were like toasting to your stupidity in the doctor's
They probably
lounge.
were.
Right.
Look at this sucker. You know what happened? They were probably all vascular surgery trainees. They're like, oh, we're going to get this guy.
Yeah.
We'll show him for touching these arteries. Because we did all the PAD at that hospital.
That's cool.
Mary, you're joining us from the West Coast. I know you got a busy clinic day to get to, but did you want anything else to share before you have to jump off?
No, not at
Okay.
all. Just I think it's super great that I am doing some weird venograms lately, like things
Ooh.
where ultrasound. Yeah, I use a lot of ultrasound, but I've got this foot venous malformation. I don't know if you really call it that. It's a
Ooh.
communication between the GSV and the tibial vein, and I tried to sclero it because I thought that would make it easy. It would go away, but it didn't work. It just sclered her GSV. So I'm going to do a venogram, old school. It's just weird. You forget that you can actually do that now. We use ultrasound, and
Yeah.
sometimes things call for venograms, and you forget that is like
In your
what we used to
armamentarium,
just
yeah.
go to.
Totally.
But
So where are you
anyway,
going to access?
I think I'm going to access in the popliteal and go down. I think I'm going to approach it from the anterior tibial. I don't know. I'm going to do it with ultrasound
fancy.
that day. What's that?
Very fancy. I love it.
It's all pipes, It's all
It's all
pipes.
glorified plumbing. Yeah.
It's all plumbing. But I have, yeah, I mean, I did another case like that. It was a pretty cool case, a young gal with a AV fistula. And I think it was post-operative, like a year after a foot surgery. She just had this bulging thing on her foot, and she was in so much pain. She couldn't walk, actually. And I think this was like 2 years ago, and she was maybe 22 or 23. She had to stop college. Like she had significant
Wow.
consequence to the point where you think there's no way this thing hurts this badly. But yeah, so I mapped it with ultrasound, and it was actually a really easy case. I just went arterial and embolized. I put one tiny little coil and shut off this fistula. I coiled across it. I could see where the communication was. So I coiled across it, and on the table, her foot just got totally normal. And that night
way.
or the next day, she went on a walk with her mom for Mother's Day, and they both like cried. They
That's
walked
so
like
awesome.
500 feet and cried. And I'm trying to remember exactly what I did, but these foot venous arterial, they don't come up that much, but it's all basic IR stuff. And I have to remind myself, like, you don't have to get fancy. You just have to go back to the basics of arteries in, veins out, find the spot, fix it.
Yeah. Very
But
cool.
anyway, yeah, the venograms, I've now done like 2 or 3 random venograms for things that I couldn't explain in other ways. And
That's cool.
so,
Yeah, I mean, that's
anyway,
one of the
have a
fun
good
parts of the
day.
job.
Hey,
What's
Mary,
up?
have a great day. Thanks for joining us. Appreciate
Yeah.
it.
Yeah, bye.
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 Let's do a check-in. Kieran, do we have anybody in the weight room?
As of now, we do not.
Okay.
They
I
must
got a
not
couple.
have heard.
I got a couple of texts. It sounds like maybe Eric Keller might jump on, possibly
All right.
Peter Horner, maybe Sabine and Donald, and maybe Peter Breen. So we'll keep an eye out for those names, Kieran. Do we have anybody viewing on the YouTube channel?
I don't.
Does it say?
I don't think so. I think
It
It
it's
doesn't
just-
show when it hits above 10,000 people.
That's it.
Yeah. Well,
Whatever. We're recording. Who gives a shit?
yeah, everybody's gonna see
Yeah, fuck
All
all
our
those
fans will see this,
guys. Yeah.
and they'll know they missed out on a great time on Monday morning.
And what a pleasant surprise, Mary Costantino,
She was awesome. She was like, "Hey, she signed right on." So
my favorite.
we did put a tweet out that just with the links. If you want to just listen in as we go on the YouTube channel, that link is on Twitter. And we did put a tweet out to call in for. It's a Riverside link. You may have to have the Riverside app on your phone, or you can just click on your email or sorry, you can click on your computer and it'll take you to Riverside by the browser. Kieran, I wonder if they could just use the browser on their phone.
I think not, but
Okay,
perhaps it's
got
worth a shot. So
Yeah,
we did
well.
just get a comment from Max Pico, who's listening at Costco on a day off,
Oh,
and Eric
lovely.
Keller is in the waiting room.
Awesome.
right.
Let's let him in.
Is that him?
Eric.
All right.
Welcome.
Eric.
Hey,
It's been a while. How are you all?
what's up, man?
Good, man. Thanks for
What are you
calling
doing
in.
today?
Well, I'm technically at a virtual gynecology conference right now, but
Nice.
that's about it.
Eric, your mic, so turn your gain up on your mic so we can hear you more.
How
Oh, you got
about
the
this?
snowball. That's right. You got the
Yeah,
snowball.
I have the snowball, but it's just because my camera's a little close. Let me move it back. There we go. That better?
Cool.
Are you using a Mac, Eric?
No, I'm actually a home work computer right now, so it's a PC.
It's PC. Okay.
Yeah.
Yeah, because you could just use the mic from the PC, right?
Yeah, I could do that too.
Yeah, just try that. Just the volume might be better because you're coming in a little soft.
Oh, we can't change it while recording.
Oh, no worries.
Yeah.
Don't worry about it.
Yeah, that's
Don't worry
okay.
about it. Yeah, you're fine. Cool, man. Well,
Tell me about this conference. Sorry, I interrupted.
yeah, go for it.
Oh, about the conference?
Yeah.
Oh, basically, it's a minimally invasive gynecology conference, kind of their largest one. I did this study comparing the relationship between IR and gynecology around fibroids before and after starting a multidisciplinary clinic. Basically, like if you hang out together as two specialties, your perceptions of each other change and whatnot. Do you hate each other less or get along? And punchline, yes. But the irony of it is that your perceptions of other gynecologists as IRs doesn't change, and your perceptions of what to do for fibroids doesn't change, but you think you're more aligned even though you're not.
Interesting. Are you going to be presenting this there?
Yeah, I presented it at SIR actually, and then
That's cool.
I'm presenting it on the other side too, Equal opportunity for me.
Good. Hey, look, that's great. We need to be doing that. It's a very interesting, innovative topic that my dense brain wouldn't have come up with.
It's more of a Vogelzang thing than it is anything. So.
Tell us how the Vogelzang interview. So, Bratza, Eric was just on yesterday with Vogelzang talking about mentorship. Tell us how it went, Eric.
It was fine. I mean, he kind of flipped the interview on me, but
Nice.
I think it worked out because we have a mentor-mentee relationship. So
Okay.
we kind of set it up as one. We kind of made fun of mentorship as a buzzword. Did like an impromptu Google search about all these like mentorship academies, the Six Sigma of mentorship and whatnot. And then we made it a little more serious about like kind of what worked with our relationship, how they're diverse. There's probably not one exact dyad, and it's kind of like dating. You kind of got to put yourself out there to find the right person. But it was a lot of him asking me like my experiences with things. So
Okay.
I
Well,
think it was
how did
good.
you find him? How did you find him in your mentor relationship?
I mean, he's great. I mean, it's different than other mentors that I've had, but I mean, I think what I liked about him was that he's very prominent in the IR community, which I didn't know. When I met him, I just learned what IR was and wanted
Yeah.
to study. I wanted to study turf wars in IR, and someone said like, "Oh, you should go talk to Howard Chrisman and Bob Vogelzang about fibroids."
Okay.
I said, "Okay." So set up a meeting, walked in there, second year of medical school or whatnot, and these people that are super established in the field just took the time of day, hung out. It was usually like Tuesday mornings, and I'd stop by and talk about that or other things, and it was more of like there wasn't as much of a power dynamic, and they were open to have these conversations and take an interest in me and give up their time, which was really cool. And then
That's awesome.
then he's just like an eclectic, funny dude.
Yeah.
Right.
I was cracking up. Mike, he was talking, it's like 36 degrees in Chicago right now, and he's saying how he just played golf yesterday. And I was like, I mean, to me, that just sounds miserable. Because my dad used to do that in Ohio, and he
Yeah.
I'd be home like for Christmas vacation, and he'd be like, Big A, come on, let's go play some golf. And I'd be like, no, absolutely not. No, I'm staying inside by the fire. Like the feeling that when that club, which is frozen, hits that hard ground, frozen ground, it's just brutal. You
Ugh.
know what I mean?
It's like the
But-
opposite of what I was talking about. Everything in Louisiana shuts down once it gets below like 60 degrees.
Yeah.
Chicago,
No, that's
like,
prime
the-
golfing weather.
People hit the pool.
Well, that's been the thing. I've become weak now from moving to California
Yeah.
from Chicago. Now when it gets like sub 50, I get sad.
Yeah. Yeah.
But,
Well, that's great. Well, Eric, were you even on call over the weekend, or were you working?
well, it's more of scanner babysitting than call.
Yeah.
That's right.
And
Oh,
outpatient
man.
side. That's why I was at that outpatient site. With
Yeah.
the glow and the nice MRI
Oh, yeah.
ambiance in the background. So.
Any contrast reactions pop up?
Well, actually, on Saturday, I had one that wasn't a real one. Someone just got very anxious and thought they had a contrast reaction.
Man, I missed that job at Vanderbilt babysitting the scanner. We had a great gig doing that when I was a resident. That I swear to you, I would do it now if I still had the option.
It's great. I mean, Stanford's constantly running these like outpatient sites, and it's like $85 an hour to sit there and do whatever
Right.
you want, essentially. I mean, you have to check the scans, make sure there's not some emergent
Right.
thing on some outpatient thing. That's it. So
Oh, so you do have to eyeball all the scans that come
Yeah.
through.
Yeah.
Okay.
only certain ones, because the neuro department doesn't trust us to eyeball their scans.
That's
So
great.
If it's a neuro one, I don't touch it. And then, if it's a knee, like a knee MRI, then I don't have to
Yeah.
look at it. It has
Right.
to be like the central torso of some sort.
Right. Like you read that, you look at the abdomen pelvis, make sure it's not like rip roaring bowel perforation from
Or like a
diverticulitis.
dissection
Yeah.
or something like that. I mean, it's been pretty rare that I found a DVT on a prostate MRI once. The patient was still there, so I just went and was like, hey,
Yeah.
by the way, there's like a proximal clot there. You should probably go to the emergency department. Like,
Do they ever run like PE scans for, like CTA of the chest, or would they just, because I mean, we used to see those all the time at Prime. It'd be like a family practice doc, and they'd send them over for a rule out PE. They don't send them to the ER. They just send them to an outpatient imaging center, which is kind of goofy.
I don't think acute PE.
Yeah, I don't think I had any. We would get like the
Like
CTAs.
CTAs.
Abdominal pain CTs and
Yeah.
and stuff like that. And like I remember one guy, they got kind of mad at me because one guy came over and thought he tore his Achilles, and they had set him up for an MRI. And I was like, nah, you're not getting an MRI. Just give me an ultrasound. Just come here for a second. And so I canceled his MRI and just like personally did his ultrasound and called my surgeon buddy. He's like, oh yeah, don't worry about anything else. And like, you're not supposed to be like canceling our scans. I
Right.
did. I went rogue.
Jeez. That's a,
Yeah, the whole
Good way.
contrast reaction thing is interesting. So Chris just had Colin Ruff on the show. Do you know Colin, Eric, or do you know the name at all? He
heard the
just
name, but I don't know.
yeah, I think he has a recent article and maybe a recent book about contrast allergies and reactions and whatnot,
Whole
and
book on that, huh?
kind of debunking some myths out there. And so it'll be a good episode. It's coming out, I think, in December. So I'll be sure to tag you guys on it.
Well, it's like a factory now. BackTable's just like cranking it out, different specialties. Like what's going on over here?
I tell you what, man, it's been awesome because we've had guys like you and Gina Landinez and Vishal Kumar and people that want to come on and also guest host and bring their own people on for different topics. So that's really what's been really helping get great content out. And like Colin reached out to us via the website. He's like, "Hey, I love the podcast," and I think he's just I think he's an MSK radiologist, but he tunes into the podcast and he said, "I really want to talk about contrast, reactions and kind of some debunk some do some myth busting on the show." And we said, "Yeah, that'd be awesome." So Chris hosted that one, but yeah, it's been really just thanks to like people like you, Eric, that like help contribute.
I've only done a handful of episodes, not like you two over here. So.
A handful is a lot. One is a
Handfuls-
lot.
yeah.
They're not easy. It's great though, having so many people involved with different interests. I like to joke with Chris that we have wildly different interests. The topics that he gets really excited about, I have literally no interest in doing, and I think vice versa. It works out so well.
Yeah, it does. And then you have Sabine who does all the high end
Yeah.
like aortic stuff and neuro stuff. So it's a great mix in terms of the host. So we're definitely fortunate when it comes to that. And then I cover all the little soft topics, so it works out.
Where's Chris Beck in all this? He's the one that covered all my touchy feely things. So
He did. Yeah. No, I was just texting because he was going to try and jump on. Hold on. Peter Horner's texting me right now, but Chris was going to try and jump on to this, but he got caught up with a case, I guess. The time is a little tricky because I think most people are starting their mornings in Central and East Coast. I never even heard back from Ari.
Now, Eric, when I said I wasn't interested in his topics, I didn't mean yours. I was primarily thinking of thyroids.
No, most people. I get a lot of people that tell me that they're not interested in.
Oh no, I'm
Steve
interested
and I
in
talked
yours.
About it actually, where he was saying about mentorship things that go wrong, and I was like, well, when I was interviewing for residency, I was trying to see, what my mentors would be at these different places. I had this one interviewer. They were like, well, you've done a lot of research. What's your favorite research project that you've done? I was like, well, I think probably studying turf wars because it's 100% me. Like, it was my idea, my thing. It's novel, and they're like, oh, no, of your real research that. So, I mean, maybe not the right fit. Not that he's a bad person, right? It's just different connections.
I get it.
Yeah. Hey, Eric, tell us a little bit about the interventional initiative stuff that we were texting about last night.
Oh, yeah. Well, it's actually what was on your show. The ethics episode, how we talked about consent and the idea of decision support aids, and if you could give something and all that dead time in the clinic workflow to the patient that talks about the risk benefits alternatives, it does consent better and faster. So you kind of win on both fronts. So that the interventional initiative took it up as their main thing now to kind of supercharge it with funding and everything. So that's what they've been doing, is developing decision aids for image-guided procedures. And they're going to roll out and beta test it in January. Peter Horner is actually going to be one of the beta test sites.
Oh, cool.
And then roll it out live. And essentially the model would be that kind of the base product would be free because it's a nonprofit, and then there'd be an option for practices if they want to customize it with their logo.
Yeah.
Some sort of subscription thing so that we can pay the people, because we have them vetted by, focus groups with patients, diverse backgrounds, different interventional radiologists and stuff like that, to try and have kind of a balanced language and picture. So in order to be able to do that, to support it.
That's fascinating. When is this going to kick off?
So we're gonna beta. Well, we debuted them at Western Angio in September. So I gave a talk there, kind of just showing it and talking about some of the data behind it. We did a trial with them at UC San Diego, and then we're gonna beta test them kind of around the end of the year / January, and see if there's any last kinks that we need to kind of iron out with how people use them and whatnot.
Yeah.
And then early next year, let it be.
If you need another beta tester, sign me up. We had a hospital that we cover recently asked me, like, hey, we need some information that, we can give patients that basically will take us from the moment the consulting physician talks to the patient until you get there, because otherwise they're completely blindsided.
Yep. So that's the nice thing, is like hospitals, it's a quality metric now.
Yeah.
And so a lot of hospitals are starting to ask for it. So the thing is that we just don't have anything like that in IR. So it'd be nice to do that, particularly in the private practice where you're doing like different hospitals, to be able to say, here's my information I give out on PE thrombolysis or something like that.
Jazz.
Totally. Wait, who let him on? Hey, Peter.
Can you hear us, Peter?
Oh, I thought you left.
Oh, screenshot. He took a screenshot.
Yeah.
Hey,
Watch
Peter.
out.
Peter, can you hear me? We can hear you.
Yep.
No, you can't hear us?
He looks like a real interventional radiologist.
I know.
Yeah, out of all of us.
He's the,
He looks like the physician.
right. Physician's office, the scrubbed out. I mean, I don't
You
know
guys
what
hear
else
me?
to do.
I can't hear y'all.
Yeah, we can hear you.
Yeah, we can hear you. If you click on speaker,
Text him. He can't hear you.
okay.
Well, Eric, before you were so rudely interrupted by Peter and his shitty microphone, you were saying the hospitals are using it as a quality metric.
Yeah, only because now there's a whole like Cochrane review saying that these sort of things improve the patient experience, likelihood to recommend all that jazz. You know? So I think hospitals.
You can hear me? I can't hear you guys.
Yeah, we can. hear you.
Yeah, unfortunately, we
This
can still
shouldn't be
hear
that
you.
hard.
Eric, I'm pumped to hear about this. I think it's a really awesome idea, and I think that I mean, I don't want to say there are a ton of applications, there's a great application for it. And you brought up a good point, in private practice. So on the weekends, I cover 3 or 4 hospitals, and that happens a lot where, we'll be in a hurry. Patient will be told by a consulting physician that he or she will probably be getting a procedure, but there is a lot of time between then and when I get there. And then when I get there, it's like, it's pretty much committed to doing the procedure, somebody with a bleed, and I'm going over there for it, and they get there with like, and I go and I have a little conversation with them and talk about it, but they already think they're getting this procedure done. And for all intents and purposes, they are. And my hospital, the one hospital I'm thinking of has asked me, is there any kind of information that we could pass out to patients, before you get there? And it's like, well, I do so many different things. It's going to be really hard for me to come up with something for every single procedure.
Yep.
Donald.
Hey, man.
Hey, man.
Donald. Yeah, can you hear us?
Yeah, I do.
Whoa,
Awesome. It worked.
What's up, man?
That's
Peter,
awesome.
too.
what?
Yeah.
Garbett's on there? Oh my god.
Yeah. Look at this.
Mike.
We made it
Peter,
happen.
can you hear us yet?
Peter. Hell yeah.
Peter,
got
can you
coffee
hear
in
us?
Yeah, I can hear you now.
his Usual.
Peter, how about that Parcels album?
This is so good, man. It's so good.
Amazing.
I love that band.
What are you guys doing today?
How are you doing post call?
I'm fantastic. I had to go to my kids' Thanksgiving performance, which was it's 7-year-olds reciting poetry and singing songs. So that describes it pretty well.
That's all.
That sounds great. I'm jealous.
If you want, I can recite the poetry. It's like really moving stuff. It's about turkeys.
Yeah, if you could send it to me,
Yeah,
I would love to listen
I'll
to it.
record it and send it out. It's gonna blow your mind. What are you guys doing today?
I got a mix. I got a Y90
Mhm.
fistula, a G tube, an F tube that pulled out, and somebody with foot gangrene.
Ooh,
PAD.
that sounds like a good day.
That's
Peter, what about you?
Nice, man. I had a UFE consult this morning, a kypho consult. I just did a left sacral ALA mass biopsy.
Ooh, nice.
That biopsy kind of heavy day. Liver biopsy, thyroid, bunch of BS. And then I've got like a tumor board thing today too.
Peter,
So-
did,
And I like.
All right, go ahead.
did you catch that fresh release, uni versus bipedicular, with Michael Brazza and Tom Andrushak? Just released today. You may not have listened to it yet.
No.
Do you do yours uni or bipedicular, your
I'm a-
kyphos?
Any particular guy.
Yeah.
Well, what's
I'm both.
really?
Yeah.
Depends on
Hey, so
depends
you
on
saw
where.
your patient in clinic today. How far in advance are you seeing him? Like between clinic and doing the procedure, how long until you schedule them?
That's a good question. It's usually 2 to 5 days
Okay.
around the insurance and everything.
Yeah. I was just curious.
Yeah.
Sometimes I'll get these calls from the, either like an ortho clinic or, whatever, the primary care physician, like, this guy is in pain, terrible pain. And then like, can you just like do the procedure? And it's like, that's always like a debate. Like, should I just like talk to him for 20 minutes before and do it? And sometimes the answer is yes.
Yeah. I think
here too.
We'll skip the consult if they're in really pain.
Yeah.
That's no one's supposed to talk about that, but but that's really, I think, sometimes in the best interest of the patient. This one's a weird one. Fracture was like in July. So
Still a lot of pain though.
I'm thinking I'm going to turn this one down. But I'm going to get new X-rays and see where it is. But yeah. So pretty quick turnaround on those. I generally do unipedicular. I think it's just so much faster, and the days of struggling with bipedicular access is, not that I ever struggle with it ever, but
man, totally get that. Not having any problems doing anything.
Do you use that curved needle, the Stryker curved needle?
Yeah, that's what I use.
Yeah.
I like it.
Sweet. I like it.
It is nice because you can direct it right to the fracture plane. You know what I mean? It's kind of nice to be able to turn it right to where you want it to go.
I like it. Sometimes I'll I'll go in with that curved needle and I'll put a little cement, and then I'll actually bring it back and direct it like either down or up and like hit a different part of the vertebral body and do it again. It's a really nice system. But occasionally I'll still do bipedicular.
Yeah, for sure. Yeah, so for me, it's a pretty light day. What do you guys got going on? You guys probably already talked about this. My most stressful part of the day was getting off the bike this morning and thinking I didn't bring underwear. So
we did already talk about that.
No underwear for the day if you do that.
You're right. It's something I worry about every day.
Kind of a Tuesday. Yeah.
Did I bring underwear?
Here.
Yeah. Do you listen to BackTable on your bike ride? Are you like a silence ambiance bike?
Yeah, that's not a bad idea. I might fall asleep though.
Yeah.
That's not good.
No. Eric, are you guys doing kyphos at Stanford, like as part of your training?
So neurointerventional does them exclusively at Stanford proper. So for the IR body people like me, we only end up doing them at the VA in Santa Clara Valley, which is our community affiliate.
Yeah. Yeah, we didn't do them at all at Vanderbilt.
Yeah, I didn't do a single one in training, and now I do them.
Yeah.
Yeah, the neurointerventional people and the body interventional people don't necessarily, jam uber well all the time. So.
Yeah.
Well, that's because a lot of the neurointerventional people don't think that we should be doing the procedures that they do. They like, if you look on Twitter, people get really territorial about like stroke and spine stuff, and too bad.
I know.
Whoever can do it well.
Well, there's IR deserts out there, right? I mean, if you're in Baton Rouge where there's not that many people doing stroke, I don't know if there are or not, but I mean, definitely probably like in Alexandria, right? Whoever can do it, whoever's capable of doing it should be doing it. So.
Yeah, I mean, that's the punchline. Like, I mean, the majority of the stroke thrombectomy stuff in the U.S. is not necessarily done by formerly neurointerventionally trained people. I mean, there's just not enough people.
Yeah.
Yeah, and we're seeing this a lot in the PE space. I've been hearing lots of sort of practice creep with cardiology and surgery, and a lot of times it's because there's not a solid IR practice in the hospital that's actually wanting to do those cases.
Right.
It's a huge problem. I know at the University of Colorado, all the spine RFAs of bony metastasis, all the complex MSK cryos and stuff, they're all done by MSK radiologists.
Interesting.
Yeah, not IR at all.
That's cool.
I feel like that's a manpower thing. Like,
yeah,
who's available? Probably.
Right.
We have, you brought up PE. We have at the hospital I'm at right now today, we do all the PEs, and at the other hospital that we do, vascular surgery kind of jumped up, and
Yeah.
so the ER will call us and vascular surgery at the same time, and it's whoever picks up the phone does the PE.
I love that move.
Yeah,
Yeah, they do that a lot here.
Who's got the fastest car or who was closest?
yeah. So
Don.
at that hospital, I
feel
kind of
it.
slow roll the phone and pick up after like 8 minutes, and they'll be like, "Oh, vascular's taking them already."
Don, I want to be the first one in this group to wish you a happy Veterans Day because these selfish guys didn't do it.
Thank you, sir. Are you
You're
military
welcome.
too?
Thank you. No, I just
Well,
recalled that you were, and
thank you.
unlike these guys, I'm grateful for your service.
I didn't do much, but thank you.
Michael's a thoughtful interviewer.
Yeah,
Thanks, Eric.
he
He
does
is.
his
He is very
research.
thoughtful.
Sorry, Donald. I had no idea. I'm sorry.
I did. I did. Anybody got anything else exciting going on this week?
Let's see.
What about case-wise?
Hey, one of my partners did a really cool case Friday. It was a HCC case, and it was a recurrence. He'd already treated him, and so he did a TACE ablate in the liver, and the patient also had a hip met. So he had biopsied it, ablated it, and cemented it. He did all that on one day.
No way.
I was like, dude, split it up. Do the liver, and then come back and do the bone. He just did it all in one day. He's crazy.
That is really impressive and super
Yeah.
fancy. That's awesome.
It is. I'm gonna post some images. It's ridiculous.
Yeah, you
He did
should.
all the fancy stuff.
Is he on social media, Don, or do you are you his ambassador and show all that stuff off for the whole group?
I'll post his cases. He doesn't. He just doesn't do it.
Look at this case I did.
I know. I get to show it off.
Partner.
That's cool. Well, thank you guys for calling in. We are this is the hour, but this is like a new thing that we thought would be fun on a Monday morning to have people kind of call in and talk about either stuff they did over the weekend or upcoming cases. We had Mary on first, then Eric, and you guys. Thanks so much for calling in. But we were just gonna kind of wrap it up after an hour, unless anybody has anything else they want to add.
No, I wish I had asked them about my GI bleed cases.
Oh, yeah.
But they
Well,
weren't very exciting. I had a light weekend with. I just had a couple GI bleeds, like a nephrostomy tube, and then just like 100 phone calls. And my question was, it was like a GDA embo, and the guy was on pressors and lost a bunch of blood. And you get all that vasoconstriction, and you go in there and you select the celiac and you shoot it, and it just looks like somebody just drew a little line across the screen. They're so small. And then you have to go sizing. It's like, normally if I were embolizing Don's GDA, I would at least go 6 millimeters. And
Have a
with
big
these,
GDA.
yeah, it's a great GDA, of course. Oregon. And so, I had to start with like 3 millimeter coils. I'm like, there's no telling what this is going to look like in 2 hours. So in the end, I ended up taking like a 5. It's like, this is way bigger than I would normally put on an artery of this size. And I just kind of jammed them in there. And fortunately, the GDA, I'm not really worried about where they fly, but something I've always thought about when people get really bad vasoconstriction or spasm, and you're trying to coil these things. What's it look like after it embolizes?
That's a good point. We've seen them recanalize.
Really?
Yeah, they look bigger later after they're recanalized.
That makes me feel better for wondering about it. They made me feel kind of dumb.
So if it recanalizes, the coil is just sitting along the wall, it's kind of thrombosed off and walled over.
Yeah, exactly. Like a little stenosed side, edge on the branch.
Side piece. Wow.
Yeah.
That's interesting. I've never seen that.
Don, I got a question for you. One that we have come up a lot on call is, where you get a stroke alert, and then you get the imaging and the perfusion will be a little bit abnormal. And then on the CTA, the only thing that you have is like the ICA will be out, just the cervical ICA, but intracranially they look good. And traditionally, if they have good filling of the MCAs, ACAs, we're kind of leaving those alone and seeing if they're candidates for an endarterectomy. But when they're thrombosed all the way up, do you ever just go after those?
Well, I'll give you a caveat that I'm on the team, but I'm not doing cases yet.
Okay.
But yeah, I don't think anybody's going after those. If the whole brain's perfused,
Yeah.
you're saying it's all perfused, but it's just
Perfused
locked
is
out.
just a little slow. It's, it's a
Yeah.
little delayed.
Yeah.
The tiny peak and everything a little elevated, but there's no core infarct.
Yeah.
That's something that we have been kind of going back and forth with.
That's a tough one because you can certainly make it worse.
That's the argument. You could stent it, you could get the clot out. And I have had one that I was talked into, and I was able to open it back up, but the brain did not get any better, and and then you worry it's going to shut down. Well, that is something we can think about for next time.
I'm involved in the cases, just not doing cases yet, but there's a lot of more sophistication now. We've got rapid, and we're talking about
Yeah, we have that too.
a lot more detail, all these different variables that we never used to talk about.
Is rapid? You have that for stroke. You also have it for PE and or anything other emergent cases.
We don't. We just have it for
No.
stroke.
Stroke.
Yeah, we just stroked as well. We haven't.
It's pretty impressive. Like I'll be around. I'll get a notification on my watch, and it'll say like suspected LVO, and it's incredible. I mean, and a lot of the time I would say, Don. I mean, probably 75% of the time it's right. They do a really good job with the perfusion scans. They give you an aspect score. It overcalls things, but it is pretty good. And the other cool thing is, you see it on there, and in the right scenario where you're really confident, you push a button on your phone and it calls in your team.
That's very cool.
Yeah, it's got some slick features. I think Viz has similar stuff, but
Yeah, I was gonna say Viz is similar. I think they're coming out with like some PE stuff for other, aortic emergencies, dissection, that sort of thing. That'd be cool. Picks up on the
there's-
imaging.
AI Doc is another one.
Yes. Yeah.
Oh, okay.
They're all jumping on the bandwagon.
I'm hoping to get all those guys on the show to talk
Oh,
about.
that would be
Yeah.
cool.
I mean, we've had
Just have
Chris
them fight?
Mancy. What's that?
Just have them fight about which
Yeah.
one's better.
Yeah, right. Which one's better? Yeah.
Have you seen? They're all all those companies. They're all on the same street in Israel.
No,
Yeah,
That's funny.
they're all
that's fascinating.
ex drone people.
It's like Music Row for AI.
Yeah, ex-drone people.
Yeah, like high tech stuff.
And Don, you have an episode coming up soon with Sabine on GI bleeds.
Oh yeah,
Uh,
yeah.
and,
What?
Yeah. Yeah.
You guys are doing GI
Sorry,
bleeds
Mike.
without me.
I know, Mike.
feel
But
really
I'll
Not gonna be there, Mike.
I wasn't invited, so no.
well, Mike's hard to. He's on call so much.
Oh, yeah. You need a
And he
partner.
talks too much.
Yeah. So, all right. Well, cool. Let's wrap it up here. I think this is great. It's a great showing.
Hey,
Loved having you
thank
guys
you,
on.
guys.
Appreciate it. Yeah. Thank you,
Appreciate
Eric. Thank you,
sharing
Don.
time.
Thanks to Peter. Kieran, just before these guys jump off, did we have any people viewing the live stream on YouTube?
Yeah, we did. People were tuning in here and there.
Oh, cool. That's great. All right. Maybe we reach
Well,
some
to
people.
the
this-
10,000 listeners, thank you.
Cool, guys.
When
You
we
guys have a
stop
great
recording,
week.
guys. Just hang out for 1
All right.
second, just so we get the
Good luck
whole.
on those cases, Don, especially that dead foot.
Yeah, we'll see. Bilateral dead feet.
Make
Even
make
better.
make them alive.
We'll do both sides.
See you guys.